Hello, my name is Rich Carter, and I am a student at Liberty University working on my Master's in Public Health. I am here this evening to go over my research program for this semester, which has to do with the needs assessment of Southwest Virginia faith-based organizations. The Department of Health for the State of Virginia, Partners in Prayer and Prevention, would like to develop a needs assessment to determine the number of faith-based organizations in Southwest Virginia that lack the necessary resources needed to address their community's social services and health issues. The mission of the Virginia Partners in Prayer and Prevention's initiative is to increase the capacity of faith leaders and community members to engage multi-sector partners and to identify strategies that advance health and health equity. The program places an emphasis on partnership and community empowerment to achieve health and well-being in all Virginia's communities. In slide number 2, we're talking about the practical purpose here. For this study, I needed to establish a needs assessment database for faith-based organizations in Southwest Virginia that are currently unaware of the resources available to assist them in setting up and providing public health and social services for their local communities. So I would apply evidence-based approaches to public health skills by collecting different variables such as the church name, church affiliation, location, the county, phone number, email, address, outreach program, funding source, and barriers to funding for the period of January 1st, 2013 through December 31st, 2018. The practicum design included a methodology for the practicum project in this section. The section is organized in 6 main paragraph segments: the project description and settings, the research methodology and design, the data collection method, eligibility criteria, search strategy, the practicum project measures, applicability of the method in meeting the research problem, the needs assessment database development procedures, and the conclusions. As a part of their mission for providing equity health care services to rural communities, the State of Virginia Department of Health provides grant proposals to help fund faith-based organizations with the necessary funding and resources. With these resources, nonprofit organizations can capitalize on providing social and health services to their local communities. Community health assessments, CHAs, and commonly community health improvement plans, CHIPs, provide opportunities for nonprofits to learn about their community and plan strategies to address issues that are identified. Some of these issues include gaining a better understanding about the population's health, factors that contribute to higher health risk or poorer outcomes in subpopulations, and the assets to improve health. The project design was based upon the development of a needs assessment database for faith-based organizations in Southwest Virginia that lacked the necessary resources for providing public health and social services to their prospective communities. The project research setting took place in a remote location where all the data collection was conducted through research on the internet using a Windows-based laptop, internet connection, and cell phone for contacting the participants. The participants were chosen based off specific geographic information provided for faith-based organizations located in rural counties of Southwest Virginia. The data collection method was the data was collected by first selecting 100 random faith-based organizations that would be contacted to participate in the assessment. A survey was created to ask general questions about the faith-based organization's current community involvement. The survey included 8 questions about community service, funding opportunities, types of chronic diseases, and the types of social services they provide. Once all the data was obtained, it was then manually inputted into an Excel spreadsheet. The data that was measured in this study was broken down into pivot tables and filtered to produce specific data analysis and figures. The variables measured in this study were the location, the contact, the public health, and social programs. A table with the number of responses was included as well. Within the practicum discussion, the findings provided in the results section were described in greater detail in this section. The discussion includes an assessment of how the practicum project addressed the requirements and needs of the Virginia Department of Health. Office of Health Equity, furthermore, in this section addresses the public health competencies that were applied during the practicum experience. The section concludes with an overall discussion of the overall practicum project experience and recommendations for future Office of Health Equity public health practicum projects. The results of planning and assessing Southwest Virginia's faith-based organizations were detailed in several different diagrams. During this phase of the project, it was difficult to come up with a number that would fit into the time frame of the practicum. However, the 100 faith-based organizations that were selected was based off a predetermination that only 25 would be selected and contacted to conduct the survey. The subpopulation was further broken down by zip code and denominations within these zip codes. These 100 faith-based organizations also represented Southwest Virginia's rural areas within the Appalachian Plateau. The communication strategy used was drawn off of a scripted call format that could be used when contacting each faith-based organizations, which is shown in Addendum 1 of the presentation. An evidence-based approach was used to select qualitative data to be used for analysis of the overall practicum project. There's data that's in the figures that represents the total number of faith-based organizations that either do or do not participate in a state-funded community partnership. Of the 100, only 16% were found to not participate. From these findings, the Department of Health Equity could engage these faith-based organizations with specific programs that would specifically fit their needs. As the practicum conclusion, the commodification of welfare services within a neoliberal economic and social environment has brought changes to that delivery of social services around the world. Social responsibility has its roots in our belief in humanity and is expressed in our willingness to assist others to come to another's assistance. Historically, social responsibility has manifested itself in services provided by individuals, organizations, and especially religious organizations. Within the Christian countries, churches aid the poor, which is typically funded by the party tithing to the church. My apologies. The goal of this assessment was to create a database of faith-based organizations lacking public health resources so that they could apply awareness of cultural values and practices to the design and implementation of public health policies and programs. The Virginia Department of Health Equity could advocate for political and social and economic policies and programs that would improve the overall health in diverse populations. Further evaluation of these policies can prove to be successful and adopted in their states or countries. The U.S. Department of Health and Human Services signifies that faith-based partnerships are no longer hypothetical. Rather, they are an ongoing part of the national conversation on public health. Under the direction of President Obama, the creation of the Office of Faith-Based and Neighborhood Partnerships, OFBNP, was repurposed from the original White House Office of Faith-Based Community Initiatives, OFBCI, created under President George Bush. Southwest Virginia simply labels this Faith-Based Community Initiatives, FBCI. While I was unable to obtain a listing of faith-based organizations the FBCI currently services, the assumption here is that the 16 faith-based organizations that stated no in their survey did not belong to this or any other governmental organization. I believe the objectives of this practicum were achieved, but limited data was retrieved to provide an adequate assessment of public health needs and require additional research that could branch from this initial assessment. One of the key findings from this assessment is that many of the faith-based organizations listed in Virginia's online directory are no longer in business. In addition, their phone number may have been changed or not readily available. Making contact was a challenge within itself. And because faith-based organizations usually operate on specific days of the week, depending on size, they were difficult to reach. The strength of this project came from the abundant amount of information available in the research documentation and the guidance provided by the practicum goals and objectives. Systematically following a structured program for each input produced a positive output. I would attribute the strongest weakness to this practicum project as a lack of time. The time constraints created limitations that if more time was allowed, could have produced a more in-depth and detailed practicum result or experience. In addition, being fully remote from this practicum project and not having the face-to-face interaction with other students and colleagues and staffing, it made it a little bit more difficult for the overall practicum experience. As a result of this practicum project, though, it is my recommendation that this project be a preceptor to ongoing assessments that surround the faith-based organization communities within those rural counties of Southwest Virginia. The relationship between government and nonprofit organization comes in a variety of different ways of arrangements, and one of those most formalized involves funding from federal grants and contacts. It will be my recommendation that faith-based organizations, specifically in the Southwest Virginia area, obtain the proper credentials necessary to apply for some of some of the states and federal grants. Some public policy and finance literature have investigated the impact of federal grants on the behavior of state and local governments, as well as examining contracting behavior by nonprofits. However, studies have not extended to the faith-based sector, specifically regarding grant funding relationships with program spending, an area of concern for nonprofit managers, donors, and other stakeholders. Through technical assistance, training, and grant funds, funders aim to enhance nonprofit organizations' functioning and ultimately improve client health outcomes. Removing barriers that could increase access to health promotion services for underserved populations, especially African Americans and Hispanics, could be better managed through faith-based organizations. However, reports on church-based health promotion interventions indicate they often are designed by researchers, address a single health issue, and usually include only one or two levels of intervention strategies, e.g., in care such as group and church services. Rarely include community-level intervention strategies and have mixed levels of success. Lastly, I recommend that Virginia Office of Health Equity develop a community-based participatory research (CBPR) approach. The Office of Health Equity includes programs and services that focus on strengthening the health of rural communities, minorities, underemployed, and uninsured citizens. They're committed to ensuring all Virginians have fair and quality health care in every corner of the state. A possible model that would work is the Faith Community Health Needs Assessment Process Model. I've attached a copy of that model within the research paper, and I would definitely recommend that be reviewed. Thank you for this opportunity, and I pray that you all have a blessed evening. Thank you.